So, the first question in Chapter 40 for management of patients with gastric and duodenal ulcers is provide the risk factors for a client with gastritis. And something I've noticed when I was like going through questions is they highly associate gastritis, especially chronic gastritis, with peptic ulcer disease. So, if you have chronic gastritis, which is typically caused by um, H. pylori infections, you are most likely going to have peptic ulcer disease. So you kind of can interchangeably use these, and you also might notice in the slides when they talk about management for peptic ulcer, it also says gastritis, and that's because they're very closely related. Um, but simply gastritis is inflammation of the gastric mucosa. And there's a few different things to think about when it comes to risk factors. Well, first, it really depends on what type of gastritis we're talking about. So let's talk about acute gastritis, just for reference, right? So when we're talking about acute gastritis, we're talking about more or less a rapid and short-term and self-limiting disease. So when we talk about that, we're basically talking about anything that has to do with dietary intake or anything that you can do is almost going to be the cause for acute gastritis. So too much intake of alcohol, too much smoking, right? Medications like overusing NSAIDs, having bile reflux or having GERD, right? Or indigesting, like, or having too much digestion of like really strong acids and like irritating foods, all of that can cause acute gastritis. And something I've noticed with that is you have a lot of hiccuping, that's typically associated with acute gastritis. And if in the question it mentions something about taking irritating foods or like really spicy foods, that would also count as irritating. That would be considered acute gastritis. So management for acute gastritis, because it's temporary, because it's self-limiting, and they're having irritation because um, of this alcohol or smoking or food, right? So they're having dyspepsia, they're having indigestion, they're having epigastric pain, right? And hiccups. Do remember hiccups. That's what I'm noticing separates this from other GI disorders, is that when we notice they're having a signs of acute gastritis, we want to refrain from alcohol intake with those patients, and we want them to not eat anything or drink anything by mouth. Okay, we don't want them drinking alcohol, and especially no food or drinks or nothing. Okay, we need to have them be the NPO until their symptoms subside, because it's very acute and it's going to the gastric acid is going to keep building up if they eat things. So because it's going to be most likely self-limiting, it's going to go away, right? We have them NPO until the symptoms subside. Whereas chronic gastritis is from prolonged inflammation, right? And yes, it could be caused from the other things we spoke about, right? Like alcohol, smoking, eating too many irritating foods or prolonged, intake of like acids. But usually it's caused by H. pylori, okay? And this is where we start associating it with peptic ulcer disease. So typically these patients are going to have like duodenal ulcers. They're also going to have mid-epigastric pain. Other things that we'll see is that they'll have heartburn. They'll have like a sour taste in their mouth, and they'll have halitosis, which also means bad breath. And early satiety, which just means they're like when they eat, they basically are filled really quickly. Those symptoms would let you know, hey, they could have chronic gastritis, in addition to what we would see for symptoms in terms of duodenal ulcers, right? So we know that with duodenal ulcers, um, we're talking about pain 2 to 4 hours after eating. And I'll explain why that makes more sense later. But I wanted to mention the differences so to get you understanding when we go into what Remy talks about, how everything makes sense. And also with a chronic gastritis, because we're talking about prolonged inflammation, problems with that mucosa, right, that barrier, right? And we're talking about a problem with digestion, right, because of all these acids, right? There's a problem. They're also going to have malabsorption of vitamin B12, okay? So I just want to emphasize that. And of course, for both of these, right, they're going to want to modify their diet, right, reduce stress, reduce those irritating foods because that's going to further hurt their chronic gastritis, but it could also make acute gastritis reoccur. So the management is going to be relatively similar, except we know that for medical management, specifically for acute, we want them to refrain from anything in their mouth. But I just wanted you to understand a little bit more about the differences. So when we're talking about risk factors, it really does depend on what which one we're talking about. But for a general sake, right, we could assume, right, alcohol, smoking, lots of carbonated and caffeinated beverages, greasy foods, smoking, overuse of NSAIDs, ingestions of acid, that would be risk factors, right? Which would also mean, they could have vitamin B12 deficiency. So those are some things that we want to think about, right? Also, we want to perform an assessment, right? So when we're talking about anything with GI, we should always be thinking, I need to do an abdominal assessment because I need to know what's going on, right? Because we notice with acute, and acute gastritis versus chronic gastritis, we're going to have a few different things. And at the same time, we're going to have Sorry. So we also want to talk about, like I said, bowel sounds. We want to see if they have any heartburn, right? Because if they have heartburn, that could let us know, especially at nighttime, that could let us know we might be thinking about chronic gastritis. We might be thinking about peptic ulcer disease in addition. So these are just things that we want to be thinking about, right? When are they eating? What time do they eat? And what happens after they eat? Because that can tell us if we're talking about acute or chronic. Something I forgot to mention, which the reason I forgot to mention it is because I deliberately decided not to mention it because I wanted to explain the difference between the ulcers. So usually acute gastritis would be associated with gastric ulcers, right? So we're talking more along the lines with epigastric pain. Um, and we're talking about pain that happens 1 to 2 hours um, after eating, and it's actually aggravated while eating food. Does anybody want to guess why that happens? Why you have pain 1 to 2 hours after you eat and it's aggravated by eating?
Because the gastric ulcer is located directly in the stomach, and when you eat, the food goes through the stomach and is that's like the location before the intestines.
Exactly, right? So the location of the ulcer is in the stomach. So if you have a gastric ulcer, it's going to hurt more when you eat because you're putting food in your stomach, the ulcer is in the stomach, all that gastric acid is being, more produced in response to the food, right? And all of that is going to agitate the ulcer, which means it's also going to be aggravated with eating. Whereas duodenal ulcers, which are more associated with, we said, chronic gastritis, which is also associated with peptic ulcer disease, as we know, peptic ulcer disease commonly affects the duodenum, is 2 to 4 hours after eating, and it's relieved when a patient eats. And that's because when they're eating, the sphincter closes in between the stomach and the duodenum. So as you're eating, nothing's going into the duodenum yet. So your ulcers are not being touched by anything, right? But when you are trying to digest your food and your stomach's trying to get that into, your intestines and, have everything go through absorption and all of that, right? It opens after 2 to 4 hours after eating, and now you're getting pain. Also, right, you can also have nighttime pain because there's more hydrochloric acid being produced at night, especially in response to H. pylori, because as we said, chronic gastritis and is more associated with duodenal, and that's associated with H. pylori. So, thinking about those things, right? Um, when they sleep, right? Let's just say they ate at, I don't know, like 8 o'clock and they decided they're going to go to bed at 10, right? Maybe at 1 o'clock they're waking up from pain. And that's, from their body just trying to do its thing. Um, Also, something else to keep in mind is that there's going to be mid epigastric pain for a duodenal ulcer, but there's going to be epigastric pain for a gastric ulcer. I just want you to know the difference. So if you see mid-epigastric pain, you should be thinking duodenal. And if I hear epigastric pain, I should be thinking gastric. Um, Other things to think about that Remy said is right, manifestations of gastritis include accumulation of gastric secretions, like we kind of been talking about, right? Loss of vitamins, especially vitamin B12 with chronic gastritis, heartburn, especially if we're talking about chronic gastritis, or indigestion if we're talking about yeah, indigestion if we're talking about acute gastritis. We talked about the different where we could see pain, right? And we talked about management, right? We want to have like a low fat diet, no alcohol, no smoking, no really hot or really cold foods. If they're obese, they should be losing weight. They shouldn't eat 2 to 3 hours before bed because that's going to increase gastric acid secretions, and elevating the head of the bed is just going also to promote, like they don't want reflux. So having the head of the bed elevated, especially having it elevated after you eat, is going to help with preventing that. Any questions or anything anybody wants to add for this question? Okay, I'm sorry I had a lot of explaining there. I just kind of wanted it to make sense. So I hope it did, and if it doesn't, just stop me and I'll try to explain it better in a different way. But the next question is to list the histamine 2 receptor antagonists, or H2 blockers, medications for management of a client with gastritis and gastric and duodenal ulcers. So we already talked about the difference between those, so we could think about that. But we know that regardless of what ulcer we're talking about, the ulcer is due to some sort of excessive gastric production, right? So we have this gastric acid that's really irritating the lining of the mucosa, right? So we want to give them medications that are going to reduce acidity. PPIs and H2 blockers do that. So what would be examples of H2 blockers? Well, anything that ends in "dine." So cimetidine, famotidine, nizatidine, anything that ends in "dine," you're gonna know it's an H2 blocker. Whereas a PPI ends in zole or prozole, like omeprazole, pantoprazole, things like that. But they both do the same thing. They both reduce stomach acidity. I just wanted to point that out. Okay. The next question is to assess and provide nursing interventions of a client with chronic gastritis and differentiate that from acute gastritis. So we already talked about that, but like I said, acute, we're thinking about more things that we do, such as how we eat, right? Our diet, are we overusing NSAIDs? Are we eating a lot of irritating foods, spicy foods, greasy foods, right? Are we ingesting too many acids? And chronic, we talked about chronic gastritis being more caused by H. pylori. So we know that H. pylori, chronic gastritis, is typically associated more with peptic ulcer disease and duodenal ulcers. So we expect them to complain of heartburn, right, from peptic ulcer disease. A very common manifestation of peptic ulcer disease is heartburn. They also have pain that occurs 2 to 4 hours after meals, and it's relieved with eating, which we already explained why, and that it awakes them up at night. Management of gastritis, we already talked about this, but just as a repeat, it doesn't hurt to keep hearing it, right? Avoiding spicy foods, avoid smoking, avoid fatty foods and greasy foods, limiting stress, limiting alcohol, avoiding steroids, NSAIDs, and aspirin because they all promote bleeding. Um, Not very good. Um, PPIs and H2 blockers to decrease gastric acid secretions, and, Pepto-Bismol, because the bismuth salts, salicylates, they're really good because they help depress H. pylori, especially with someone who has chronic gastritis, which actually helps in healing the mucosa of the GI tract. So that's what Pepto-Bismol does. And that's why it's also given as one of the triple therapies when someone has an H. pylori infection, because it just helps with the healing. Okay. The next question is to define, assess, provide complications and diagnostic imaging of a client with peptic ulcer disease. Now, just as an explanation for peptic ulcer disease is that it's ulceration of the stomach or the duodenum because of mucosal tissue destruction due to some sort of erosion in the stomach, pylorus, duodenum, or esophagus. But it's mainly the duodenum. That's why we typically see duodenum ulcers or duodenum ulcer manifestations in someone with peptic ulcer disease. That's what you should be thinking about when you're thinking about manifestations related primarily to what we talked about when it comes to what do we see when someone has duodenal ulcers. Um, and remember, we're having peptic ulcers because there's an increase with that gastric acid, and as a result, the body can't handle it. Um, Risk factors, same thing, right? Overuse of NSAIDs, H. pylori, which is the usually the primarily the cause, corticosteroids, um, right? We talked about when you take steroids, you have to rinse your mouth. That's because they can cause ulcers. Now imagine you're taking that in addition to having peptic ulcer disease, that wouldn't be very good, right? Uncontrolled stress, smoking, caffeine, alcohol, diet, and type O blood patients actually have a higher risk of getting peptic ulcer disease than any other blood type. Um, okay, so clinical manifestations. I already mentioned heartburn as one of those common manifestations, right? They're also going to have a pain, right? We said pain a few hours after eating, like that 2 to 4 hours, and they're going to have like that burning sensation in the mid epigastric because that's associated with duodenal ulcers. So everything starts to come around, right? Um, but what Dr. Remy said is assessment. This is what we're thinking about. We're thinking about what the disease is, how it works, and what it's caused by, right? We know it's an erosion, we know it's due to gastric acid, and we know that there's a lot of things that we do in our life that could cause it. So we want to ask the patient, do you drink often? Do you smoke a lot, right? Or do you do any drugs, right? Do you, when you ask them if you have any blood in your stool, do they notice that? Um, Ask them if they take a lot of over-the-counter medications like NSAIDs, or do they have, a steroid medication prescribed to them. We should do an abdominal assessment on them, right? Because we know that peptic ulcer disease has quite a few different complications. One being GI bleeding, another one being perforation and penetration, another one being gastric outlet obstruction, and even peritonitis and infections, right? So we have to be thinking about, we should be looking for any sort of bleeding or signs of bleeding. We have to look for signs of ulcerations, right? Potentially peritonitis and even gastric outlet obstruction or just things being built up in that GI tract and then not really able to go. So we want to think about those things. So that's why we want to do a good abdominal assessment and ask them about their bowel movements, if they have any blood anywhere, things like that. Their manifestations, such as when they eat, what sorts of pain do they have? Do they have any pain when they eat? Things like that. Um, and yeah, is there anything anybody wants to add?
No.
Okay. So, before I get into the next question, I just wanted to add some things. So, if one of the goals for a peptic ulcer disease, right, we want to relieve pain, but we also want to make sure there's absence of complications and providing good nutritional support, right? Because someone who's having pain a lot, especially when they're eating, they might not want to eat or they might become malnourished. Um, So, thinking about that in mind, and especially since we want to prevent complications, right? We want to think about if they have a GI bleed, right? We ask them, have they seen blood in their stools, or do we even notice any blood in their stools? One of our priorities becomes restoring fluid. And when they have a GI bleed, we also want to have an NG tube there for the hopes of aspirating GI contents and helping to decompress the stomach. Gastric outlet obstruction, actually, the first thing that you do would be an NG tube because of the fact that they decompress the stomach, but also what helps confirm if a patient has a gastric outlet obstruction or a lot of stuff going on in their, GI tract, like things building up, is that if they're able to pull or aspirate 400 milliliters of fluid, that signifies that they probably are having obstruction. That's what helps confirm it. So gastric outlet obstruction, you should be thinking my first priority, if I do notice that complication, should be getting them an NG tube. For a GI bleed, you need to restore fluid, which will be right blood and also actual fluids, right? Um, for peritonitis as a complication, they could have severe upper quadrant pain. Now, I also want to add in that perforation and peritonitis both have a rigid abdomen. Like they're both going to present with that. So I just wanted to let you know that. So if you ever see a question and you're like, peritonitis isn't there, but perforation is, they can both have a rigid board-like abdomen. But with peritonitis, they're going to have a rigid board-like abdomen with rebound tenderness. Um, Perforation has a rigid board-like abdomen, but they have severe upper abdominal pain that typically refers to their right shoulder. So that's like a slight difference between those two. For me, I find GI disorders to be very similar. That's why I like to mention the differences. So hopefully it helps you. Um, and yeah. So if we do have to give them an NG tube, right? Especially if we're talking about gastric outlet obstruction or if we're talking about GI bleeds, right? It's for the purpose of decompressing the stomach and aspirating contents. We know that they're at risk for which electrolyte imbalance?
Is it hypokalemia?
Yeah, they're at risk for hypokalemia, so we want to make sure we monitor electrolytes. We want them on intermittent suctioning because too high would be, really bad for the stomach and can actually hurt the lining of the stomach. Does anybody remember the number that it should be at for intermittent?
60 to 80.
Mm-hmm. And we also want to think about this as an NG tube, right? We're pulling things from it. It's helping to decompress the stomach. So we want to assess what's coming out, right? The coloring of it it should be like dark brown, dark green, yellow green. That's okay. Um, Typically when you're going to irrigate, you're going to use sterile water. And you want to monitor intake and output, right? Because they should be outputting something. And if they're not, right, there's no drainage coming from this NG tube, that's a problem, and the doctor needs to be notified. But that's what I just wanted to point out with you guys, just as I to help a little bit. But okay, so the next question is to perform a physical assessment of a client diagnosed with chronic gastritis, provide nursing education to limit exacerbations. So pretty much everything we said, right? We're thinking chronic gastritis. We know it has to do with H. pylori, so we know there's probably going to be antibiotics prescribed with this, with that triple therapy. But it's also, right, we're also going to have all the other interventions like limiting stress, stopping smoking, diet changes, right? Avoiding spicy, greasy foods, not eating 2 to 3 hours before bed, sitting upright after eating, and avoiding NSAIDs, steroids, and aspirin, and limiting alcohol. Next question is provide the characteristics of duodenal ulcers, location, and provide nursing management. Once again, duodenal, we know chronic gastritis will have duodenal ulcers, which is also related to peptic ulcer disease. So we know that we're dealing with, right, antibiotics, especially triple therapy, which includes amoxicillin, um, metronidazole, and clithromycin. And with that, PPIs and Pepto-Bismol will be added. Like we said, Pepto-Bismol helps with the healing, and the PPI helps with decreasing acid secretions. We said we know that we're gonna see them have mid epigastric pain, that they're gonna have pain at nighttime that wakes them up, and they're gonna have pain 2 to 4 hours after eating, and it's relieved with food, um, relieved when they're eating. Um, Okay, and that the doctor could also order Carafate or Sucrafate for elderly patients, which is like a type of antacid, according to Dr. Remy. Um, okay. The next question is to identify the causative factors of Helicobacter pylori, H. pylori, clinical manifestations, complications, nursing management, and be familiar with the therapeutic regimen for peptic ulcer disease. So, Dr. Remy said that the causative factor for H. pylori is due to an infection from excessive hydrochloric acid. Okay, so H. pylori is able to get into, a patient's body as an infection because there's too much hydrochloric acid, which is ruining or destroying the lining of the stomach, right? So we already know antibiotics, PPIs, H2 receptor blockers, and we're also thinking manifestations related to duodenal ulcers. Okay. The next question is to perform a nursing assessment of a client post-gastrectomy, assess psychological status, and provide appropriate nursing interventions. Now, what is one of the biggest complications from a gastrectomy?
Dumping syndrome.
And what is dumping syndrome?
It's like food passes really fast into the small intestine, like the duodenum.
Hmm. Yeah. So post-surgery, the problem is that when they remove, part of the stomach and that area, as you said, right, the food just goes really quickly through it and it makes them feel like really dizzy and they'll have palpitations and they're not going to feel good until after they pass a bowel movement. So when they have that, what we want to do is they should have small, frequent meals. They should have low carbohydrate diet. They should have they should actually lie down after they eat, and that's because lying down for 30 minutes after they eat actually slows gastric emptying, which actually helps with those manifestations. They don't feel really dizzy, not have these palpitations, they don't feel nauseous. They should eat actually a low carbohydrate meal, and that's because they're at risk for postprandial hypoglycemia. So I was kind of thinking about it, like why it makes sense. And to me, the way I thought about it was imagine you're eating a lot, like a lot of carbohydrates, right? And in response, your body is just producing a lot of insulin in result to these high carbohydrate meals. So it's best to have lower carbohydrate meals so not as much insulin is produced, so the sugar level of your body doesn't drop as much. Um, they're also at risk for vitamin B12 deficiency because of, just too fast the body going through trying to get the food, down into the digestive system and it's just not getting absorbed. And if they have psychological issues, right, we need to focus on the stress, like the anxiety that they might feel with it, right? And we should provide empathy and, show them that we're there for them and things like that. And ask them, is there anything that we could do for you now? Um, Okay, so the next question is assess and provide clinical manifestations of a client with ruled out gastric perforation and peritonitis and provide appropriate interventions. So Dr. Army was mentioning like a motor vehicle accident and they had like collision, you could suspect that they could have perforation. Um, of the of like the gastric, I don't know. But yeah, they could have perforations if they have a motor vehicle accident, which could make sense, right? Like they could have something that could have went through, right? We don't really know the whole details, but she was saying like we need to think about what sorts of assessments we need to do, right? So if we're talking about GI, what kind of assessments do you think we would have if we're trying to rule out any sort of GI issues?
The patient could go into shock if they're like losing too much blood or fluid.
Right, so we need to watch vital signs for increased heart rate, right? Low blood pressure, cool and clammy skin, right? They said that they ruled out gastric perforation and peritonitis, but there's other things that we could talk about, right? So we want to maybe do a small bowel follow through to see for obstructions, right? But Dr. Remy said no NG tube until the results are back, right? We want a CBC to look at hematocrit and hemoglobin, see if they're bleeding, IV fluids, X-ray, endoscopies, right? They should be NPO because we don't really know what's going on and we don't want to put anything in there that could, especially if they have obstructions. A serum gastrin level, assessing for pain. So, sorry. I dropped something and I had to get it. But yeah, so we're thinking about all of these different things, right? Especially if they have like a motor vehicle accident, that's a situation. We want to have a good abdominal assessment. We want to make sure we look at like a stool antigen test. We want to see if there's any blood. things like that. And ABGs, right? To let us know really what's going on with their levels. Especially if they start to become unconscious, this could be a respiratory or even like a metabolic issue. Is there anything that anybody else wants to add?
No, you could continue.
Okay. Um, so, the next question is to assess and provide clinical manifestations of gastrointestinal obstruction and identify the causative factors. So, kind of similar to like gastric outlet obstruction, right? We're talking about things being blocked up in there, right? In the GI tract, and it's not really being able to come out. So obviously we're thinking, okay, this is a GI issue. We need to do a GI assessment, right? And we're going to expect them to have absent bowel sounds, right? Because if things are blocked up in there, things are not going to really be flowing. We should ask them about when their last bowel movement was, have they been passing gas, things like that. We should be looking at their vital signs. Like someone mentioned before, we could be at risk for shock with that patient, so we want to look if they're hypotensive, tachycardic, weak pulses. If they have a fever, that could be indicative of like peritonitis or perforations. Um, they could have a decreased level of consciousness. Um, their labs are going to also say different things, right? A decreased CBC, MCV for iron deficiency and platelets. That could show, hey, this patient's bleeding, right? Especially if they have a low hematocrit and hemoglobin. They could have elevated BUN and creatinine from kidney failure, especially from just constant blocking of the intestinal tract could lead to, right, potentially, ischemia and problems with the blood flow, and that could all get back to the kidneys, right? If the intestinal obstruction gets really bad, it can go into paralytic ileus, and they could have projectile vomiting. So we want to look out for that, right? Especially if they start complaining of nausea. And we're gonna see, right, a rigid board-like abdomen, right, especially if they could have peritonitis as an additional complication to intestinal obstructions. And of course, as we talked about, gastric obstruction, one of the first things we need to do is an NG tube to decompress the stomach and to really help aspirate GI secretions and make it, you know, to determine if they actually have gastric outlet obstruction and to see what we need to do to get the nutrients and things like that. Okay, so, um, and just as like a quick thing is that with nursing management, one of the things is maintaining the function of nasogastric tube as one of the first things in assessing and measuring, because that's what you need to do when someone has an obstruction. Um, you need to have a NG tube there. Okay. The next thing is to conduct a nursing assessment of a client with an ileostomy and determine the patency and complications of a functioning and non-functioning intestine with an intact ileostomy. So, what are some things that would let you know, hey, this ileosteum, this is working for my patient? Well, an ileosteum is going to be an opening in the ileum. Now, just so I could show you, so maybe it helps a little bit more, right? Is that your ileum is going to be on your right lower quadrant. And essentially, when we do an abdominal assessment, you always start with the right lower quadrant, and that's because of how um, the bowels should normally work, right? So when the food goes through the intestine, it goes through the ileum, then through the ascending, then it goes in the transverse, which is in between the right upper quadrant, the left upper quadrant, then it goes down into the descending, and then it goes into the sigmoid and the rectum in that left lower quadrant. That's why we always start with the right lower quadrant. But regardless, the ileum is in the right lower quadrant. So just thinking about that and thinking about, okay, we're talking about an ileum, right? So in ileostomy, it should be on the right lower side. We should expect liquid stools because it's going to be liquidy, and as it continues in the colon, it's going to get thicker. So the ascending is like semi, um, is like semi-liquid, the transverse is like semi-formed, and once it gets to descending, it's formed, right? So we want to see liquid stools. The stoma should be pink, moist, and shiny. Um, also, we also want to think about, okay, what about ostomy care or specifically ileostomy, right? Well, regardless of the type of ostomy bag, there should always be skin prep, a drainage bag, making sure you always pat and dry the ileostomy when you're changing it, and you could use warm water to help clean around its skin barrier. A wafer, which is, I think it's like that circle that goes around the stoma, that needs to be the correct size. And you want to secure that wafer, or else that stool is going to come out. So those are different things that we need to think about. We should also be careful of our verbal and nonverbal responses because that could have an impact on the patient, right? They might feel a certain way if we look at them, funny or make them feel a certain way. Um, there's fungal powder if they have a fungal infection due to the ileostomy. We can give myostatin powder at the site. We should be teaching about what we're doing and what sorts of potential complications they should have and how to, correctly do the skincare, the prep, all of that. That they could have charcoal filters to help with the odor, that since this could be a fresh ileostomy, depending on the case, right? If it says it's a fresh one, we should let them know that the stoma is going to take 6 to 8 weeks to shrink. So it could look a little edematous. And according to the textbook, it said that 600 to 1200 milliliters of daily output is normal. So we should be telling them, you should be measuring it to determine, if if your ileostomy is functioning properly. Um, Other things to think about is if this is post-operatively, right? Let's just say they're day one, we should expect that they'll have liquid stools coming into that ostomy bag within 48 to 72 hours of the surgery. If not, there's a problem, right? We're also we want to ask them about their bowel movement history, like, ask them like, have you been since the surgery, or even having it, are you passing gas, are you noticing liquid come out, how much liquid? Um, if they have a JP or a hemovac after, we want to assess the drainage and characteristic of that as well. And also, they're going to be at risk for body image disturbance and sexual disturbance because they might feel a certain way, like having a bag on them. It might make them feel a little self-conscious. So those are nursing diagnoses appropriate for this patient. Also, self-care deficit, as they might not know exactly how to care for this, and they also have, for this one, potentially a fluid volume deficit, and that's because of the fact that they're losing a lot of liquid into that bag. So if it's more than that 600 to 1200 daily, that could indicate, hypovolemia. So we need to be careful with that too. Um, and we should tell them that if we want them to avoid like a smelling odor, that they should avoid foods like cabbage, spinach, onions, beans, yogurt, alcohol, broccoli, parsley, garlic, all of those, especially like the greeny food, can be more gassy, and nuts, chocolate, and seeds can cause constipation. So those are some things they might want to avoid. The next question is develop a nursing diagnosis based on priority of a client with intestinal obstruction and provide the rationale of the disorder. Um, so I have for this question that Dr. Remy said, ineffective tissue perfusion related to intestinal obstruction evidenced by absent bowel sounds, right? Because imagine this, you have so much obstruction, right, that it's just building up in that colon area, and it gets so bad that it actually starts to impede blood flow. So our priority for this patient would be ineffective tissue perfusion. This wouldn't really be a respiratory issue, even if we saw it, because it's not like a respiratory, it's not going to cause respiratory complications, right? We're not seeing in these, I mean, of course, there's always something that could happen, but in terms of intestinal obstruction, the priority is going to be ineffective tissue perfusion. Is there any questions or anything anybody would like to add? Okay, so the next question is define Crohn's disease and ulcerative colitis, causative factors, and clinical manifestations. So, basically, Crohn's disease and ulcerative colitis are both inflammatory bowel diseases, okay? Crohn's disease can also be called enteritis. So, what I want to point out is the main characteristics between them. So, for Crohn's disease, I like to think CC, Crohn's constipation, because constipation is the main symptom. They're also going to have right lower quadrant pain, and that's because it affects more of the ascending colon and the ileum, and they're also at risk for metabolic acidosis. Um, Other things that I wanted to add is that it could be caused due to fistulas, fissures, and abscesses that form this inflammation. And they also have ulcers. So, ulcerative colitis and Crohn's disease both have ulcers, but the ulcers in Crohn's disease um, have a cobblestone pattern. And they're causing inflammation because they're weeping this irritating discharge into the colon. Whereas ulcerative colitis is in the lower left quadrant, they're going to experience pain, and that's because it affects more the sigmoid and the rectum. This is more of a bleeding issue, so the mucosa is going to be very bloody and inflamed. So for these patients, we expect to see potentially blood in their stool, whereas we wouldn't expect to see that for someone who has Crohn's disease. And for ulcerative colitis, the main symptom is diarrhea, whereas especially bloody diarrhea compared to Crohn's disease, which is constipation. But regardless, we're talking about ulcerations, we're talking about inflammation, and we're talking about either problems going or, going too much. So we really need to have a good bowel assessment, look at analgesics, have monitor daily weights, I&Os, looking for symptoms of dehydration or fluid loss, maintaining nutrition, making sure that they have foods that are high in protein or low residual, especially if they have a parental line. Um, and we want to reduce any sort of anxiety. Okay, the next question is to define the pharmacological effect of parental nutrition and indicate the client at risk. Indicate admixture of parental nutrition and complications of a client receiving parental nutrition. So, does anybody know what, or let me say, where parental nutrition is going to be administered?
Central line.
Right? It's a central line. So when we're giving total parental nutrition, we're talking about a central line or a line that's going towards the heart, right? And the admixture or what it has in it is it has lipid emulsions, protein, water, electrolytes, carbohydrates, um, vitamins, minerals, and even glucose. So, because it has sugar, because it has all of these things, they're at risk for hyperglycemia and they're at risk for infections. One, because of the hyperglycemia. Anywhere sugar is, there's a risk for infection because bacteria like sugar. And they're also at risk just because it's a central line that invades the heart, very invasive. So, one of the reasons why, or at least a reason that I saw that course point defined as the main reason, is that they have an impaired ability to ingest or absorb food orally or enterally. Other reasons can include insufficient oral or enteral intake, the patient's not willing or unwilling to ingest foods orally or enterally, and they basically have prolonged preoperative or postoperative nutritional needs that haven't been met, so they give them total parental nutrition. But the main reason, at least from what I've noticed, is impaired ability to ingest or absorb food orally or enterally. So, of course, right, we need to assess, make sure this patient is a right candidate for that, right? Looking at their nutritional status, their I&Os, right? Seeing if they're having any weight loss, because they're going to have weight loss, especially if they're having prolonged lack of food orally or enterally. Um, which also makes the nursing diagnoses make a lot of sense, right? So, impaired nutritional intake related to inadequate oral intake of nutrients, risk for infection associated with contamination of the central line, fluid imbalance with altered infusion rate, and they have a risk for activity intolerance, especially in the presence of this IV access. Um, Now, does anybody know what sorts of complications or problems we could see with someone who has a TPN? Well, one of them is infection, right? We talked about the idea of the sugar. So they're at risk for things like sepsis. They're at risk for like pneumonia thorax and clotting because it's a central line and air or air embolisms can get into it. Um, they're also at risk for hyperglycemia, as we saw, because of the what's in the TPNs, right? They could be at risk for fluid overload because they're getting fluid that's through the central line, and too much of it could be harmful. And they could even have rebound hypoglycemia, especially if it's just stopped abruptly or you run out. Now, does anybody know what we give to them if the TPN runs out? Which type of fluid we give them?
Is it dextrose 50%?
Dextrose 10%. We're going to give them dextrose 10.
Sorry.
No, no, it's okay. But I want you to get it right on the test because she might put all of them. But it's going to be dextrose 10% is what we're going to switch with as the compatible fluid if the TPN we don't have it or for some reason, we had to stop it. That's what we're going to switch. So yeah, we have to think about things, right, for the TPN, like with maintaining nutrition. So always we want to look at the electrolytes, the INOs, daily weights based on what's in it, and finger sticks. We know that this is a central line, so we need to have sterile technique with occlusive dressings, using chlorhexidine to clean it, which is antibacterial, and making sure when there's dressing changes that the patient wears a mask and we wear a mask while doing the dressing changes. Um, and we want to maintain their fluid balance, right? So same thing, right? Daily weights, INOs, electrolytes, and making sure that we don't change the infusion too quickly, such as increasing it too much or decreasing it too much, because that could also have problems. Um, okay. The next question is to provide appropriate action by the nurse of a client post hemicolectomy and assess the psychological status um, of a client with the creation of a new coleostomy. So if the patient's anxious, right, what we want to do is refer them to the ostomy nurse, and that's because they can provide a lot of education and they have a lot of experience with patients who receive new ostomy bags. They can help them with the teaching, with how, to do the daily care for it, and just make them feel much better, I think, in terms of how they're going to manage this when they're out of the hospital, which is what Dr. Remy was saying. And we talked about, right, the diagnoses for anyone who has ileostomy or colonoscopy has to do with self-care deficit, sexual disturbance, and body image disturbance. So that's going to be the main thing, right? They're going to feel very anxious about those things. The next thing is to assess and provide nursing management of a client with a diagnosis of diverticular disease. So, what I want to emphasize is that for someone who has a diverticular disease, it's typically a herniated sac in the sigmoid, right? We're talking about that sigmoid or the lower left quadrant. So, typically, patients have diverticular diseases due to having a low fiber diet. So if they're having a low fiber diet, they're at risk for constipation. So just like Crohn's disease, diverticular disease has to do with constipation. So what we want to do is um, assess their, bowel movements, but also provide interventions that have to alleviate symptoms related to constipation. So what are some things that we could do to help alleviate constipation?
Increase fiber.
Yeah, we could increase fiber, especially because this is low fiber, right? So we want to increase their fiber. We also want to increase their fluid intake by, according to the textbook, 2,000 liters a day. Um, I think it should be milliliters. I don't know. Um, I think it's milliliters. 2,000 milliliters a day or 2 liters. Um, but they should have soft foods, right? Fiber, like things like cooked vegetables, and they should exercise. So I always think increase exercise, increase fiber, increase fluid are always your three go-tos when it comes to anything that has to do with constipation. And if we see diverticulosis, that's herniation or diverticula without inflammation. And if it talks about diverticulitis, anything that ends in itis means inflammation. So this is inflammation and infection of that area. Okay. The next question is to
I have a
identify.
question.
Oh, no, no, go.
So, yeah, so the nursing management for diverticulitis and diverticulosis is the same, right?
Yes.
Okay, great.
Okay, so the next question is to identify complications of a client receiving parental nutrition and provide nursing action. So we talked about this being a central line. So we said some of those things include like pneumonia thorax, air embolisms, clotting, or even dislodgement. They can have sepsis, hyperglycemia, fluid overload. They could even have rebound hypoglycemia. Those are the things that we want to look for. I feel like this might be more of a select let apply question, or just being able to recognize what sorts of complications we could see with someone who has a TPN inserted. Okay. Then last question is provide patient teaching of a client diagnosed with gastric cancer and focus on preoperative teaching. So, gastric cancer, once just like almost all the GI disorders, right? It can be caused by things like smoking too much, not having enough maybe hydrochloric acid or a chlorhydria, gastric ulcers, could be due to a previous subtotal gastrectomy, diet, H. pylori, all the stuff that we kind of talked about before, right? But the problem with this is that it has a poor prognosis and it's, diagnosed often late. And that's because, right, if let's say you're having like indigestion, right, which is a symptom, you have pain, but it's relieved by like antacids, you're having maybe a bit of weight loss or a decrease in appetite. You might not notice these things right away until they become progressively worse. But as any gastric related disease, especially because it's closely related to things like peptic ulcer, based on if it could be H. pylori, it could be due to having like chronic gastritis. So it said it could be due to chronic inflammation of the stomach. So we want them to have like, the small frequent meals, don't drink during eating. I think always, also something, I don't know if I mentioned that specifically with dumping syndrome, but any of these like GI disorders, always, if it's going to say eat, and something to do with fluid drinking and eating, it should always be eating and drinking between meals, not with meals. So even if it says, oh, eat 6 small frequent meals with fluids, no. It's got to be eating 6 small frequent meals and drinking fluids between meals. I just wanted to like point that out. So yeah, do not drink during meals, drink between meals. There could be vitamin deficiencies, so we need to watch out for that, like vitamin B12. We should have INOs, daily weights, electrolytes, and taking a caloric count. And we want to know especially about their dietary history, right? If they have a smoking and alcohol history, and we want to have a good assessment of the abdomen, right? Because can have all these things, right? Bloating after meals. That's something I noticed on one of the questions, talking about a lot about bloating with meals that could be with gastric cancer, dyspepsia, weight loss, things like that. So we really want to have a good GI assessment, and we want to promote nutrition and things like that. And yeah, if does anyone have any questions or anything else to add?